Pues vamos a seguir con diagnóstico y ahora vamos a ir con la fase de biomarcadores. Y para eso contamos hoy con el profesor Hans Lilja del Memorial Sloan Kettering Cancer Center de Nueva York. Tenemos la suerte de contar con él y nos va a hablar de 4K, del 4-calicreína y la mejora que se puede realizar con la 4-calicreína en el screening del cáncer de próstata. Directamente.
Thank you, dear chairpersons, for the introduction, and many thanks to the organizer of the meeting, Dr. Astrobieta, for inviting me to come to Bilbao, where I never visited before, and where I certainly would agree to what's put forward as reasons for us to attend the meeting, namely that Bilbao is a city very well worth visiting. Though coming from rainy and pretty bad weather in New York, I noticed some similarities, though, upon my arrival here, weather-wise. Another comment and a challenge is, of course, that some reasons to attend our meeting is that the PSA test is not the prostate cancer marker. I think we can come back and discuss that in the Q&A session with the panel once I've had the opportunity to provide the arguments as to why I think that is very clear evidence that PSA in the blood is associated with important prostate cancer endpoints. As said, I am at Memorial since 13 years ago. I was educated in Sweden, and since almost 4 years ago, I have a secondary appointment also at University of Oxford at the Department of Surgical Sciences. Part of my presentation will involve biomarkers that we have detected and constructed assays for, and these biomarker assays have been commercialized and are for sale in the diagnostic marker. So I should make these disclosures so that's clear to the audience about my presentation. Now, we have touched upon it, but not really discussed it yet. But it's frequently being discussed and commented that the European randomized screening trial has data that are contrasting those to the US screening study, the PLCO trial. So let's look at that argument and see where that argument falls. Because the European randomized screening trial, if we now look through the report from our 13-year outcome data, show very clear reduction in cancer deaths in absolute risk reduction. The but is, of course, that it also shows very clear evidence of overdetection, overtreatment. And this is then shown in a setting where the study started to study a population not previously subject to screening. So why the PLCO data are not contradictory to the European data? Because the PLCO, as everyone knows, by 13 years shown that there was no difference between opportunistic testing and systematic testing, and no evidence of a reduction of cancer mortality in that setting. It had a smaller sample size, about half or less. Many participants, more than half, had been subject to PSA testing before being invited. More than half of the control group continued PSA testing, whereas very little PSA testing obviously was going on in the control group of the European trial when that started. And also, perhaps often not commented on, but the biopsy compliance in the European trial is very high, 87%. In the PSO, amongst those screen positives, it's below 50%, it's somewhere in the range of 47%. However, given then that the benefits in terms of cancer, reduction of cancer mortality, could be clearly discussed whether or not there is a proper balance between the benefits and the harms from toxicity of treatment given to all men. In the US setting, the US PSDF, as we all know, the Preventative Services Task Force of the US government, issued in 2012 a recommendation against PSA screening, stating that there was no net benefit or that the harms outweigh the benefits, so in principle discourage the use of PSA screening. Why did they do so? Well, even if we don't agree with their conclusion and some of the arguments as to how they came to their conclusion, it's obvious that they had a case. Because in the cases that screening and consequent treatment, as practiced at that time at least, were or it may still be considered to often be harmful. So, indiscriminate screening of elderly men with short life expectancy, liberal criteria for biopsy, aggressive treatment for individuals with low-risk cancer, not sufficiently aggressive treatment for individuals with high-risk cancer, and then a large amount of the treatment being given by low volume or not very well-trained individuals. Here is a graph showing the distribution of PSA testing according to age in the US population in a presentation that came from Scott Eggener and his group in JCO in 2011. And as you see here, very much of PSA testing at higher age, and also shown in other publications amongst individuals with high degree of comorbidity, and very little, very much less of PSA testing at lower ages. So, in fact, it's clear that although the European trial shows that we can reduce cancer deaths, the way that screening was set up and tested and looked upon provides an uncertain balance between the harms from overdiagnosis and overtreatment compared to the benefits in terms of cancer mortality reduction. So we have then, during a longer period of time, looked at different ways on how we could improve screening. And I will present this in two settings. One is, and the first one, is the risk stratification for screening. And the second one is the risk stratification for biopsy, how we can use additional markers to improve the specificity of finding something that is a significant lesion with a significant risk or morbidity during your lifetime. So what we set out to do more than 10 years ago was to try to define something that was lacking in the literature at the time, namely the natural history of the relationship between lethal forms of prostate cancer and PSA. And to define that, you would need a population that was very little exposed to any PSA testing. you would need bloods collected and properly stored so they could provide relevant information without any decay of the samples and so on. And then also high ascertainment and very long-term follow-up. And all this was provided to us in my old alma mater at Lund University and the city of Malmö, where during my med school studies, Professor Hood set up a study inviting all men in certain age groups, age 33 to 50, not every age group within that, and also then an age group with men age 60, and that was done during 74 to 86. And as we know, during this time, the PSA test wasn't around. So 22,000 men plus came and provided blood. And then as Malmö is a city with only one hospital where cancer care, and particularly prostate cancer care, is given, and then Sweden is has a system where you can, by your patient identifiers, with proper consent and approvals, match to the cancer registry and get accurate update in terms of cancer incidence. And then there is additional registry data that you can match to the population sample. And then, given that there was a large biorepository of cryopreserved EDTA plasma, which provided levels that correspond to those contemporaneously measured, and that was something that we published on in Clinical Chemistry, comparing with the European randomized screening trial. We then started to reporting on the natural history of prostate cancer, and then focusing not during the first papers we published from this cohort, but in the later papers that have appeared in British Medical Journal here during 2010 and 2013. This is then for the age group of 21,000 men aged 33 to 50. It then has accumulated to almost 1,400 prostate cancer detected, but more importantly, over 240 metastatic cases and more than 160 cancer deaths. And when we compare these data, which has a median follow-up of 27 years, we can see that in PSA measured at age 45, 49, and then when we follow these individuals during very, very long time, we can see that that PSA collected at that time has a very interesting characteristic in terms of its powerful negative predictive value for a large proportion of the men who then stay at very low risk. So here is the bottom three quartiles of men with their PSAs, where, for example, 0.7 is the median, and 1.1 is the second highest quartile. So that means that all men below 1 or 1.1 continue to be at very low risk during many years, versus individuals then with quite modest elevations in the top quartile or the top decile, then provide quite staggering increased risk. And if we look at a hazard ratio here, it's more than 15-fold higher risk for these individuals here in the top decile, with, as we see, a quite modest PSA elevation. And quite substantial lead times until the event of distant metastasis. If we go to an age group 51, 55, provided by that some individuals provided a second sample, we can see that very similar findings appear, although we can see that distant metastases appear earlier. Levels are adjusted somewhat higher. The overall risk becomes higher, and we see that the tail, which we see a tendency of here, becomes more prominent. That means that likely, if we start this early, a single PSA at, let's say, mid-40 or late 40s is likely not enough for lifetime. But it provides you with a risk estimate that is very low during many years, and certainly up to 15 years, as given here by the absolute risk for a PSA below median, below 0.1% here, risk of metastasis in the 40s, and in the early 50s it is below 0.3%. And then complemented by the study that appeared slightly earlier with the man age 60, followed for 25 years, we can see then that the claim that PSA has a lot of noise is to some extent true, and I'll come back to that. But if we look at that in its association for death for individuals who have never been screened, were invited in 1981, were 60 years old, had reached 85 years or died, and where we look at the association for PSA with death within 25 years, it's 0.90. It's actually pretty good. I think it's undoubtedly very good. And for example, if we look at gene stratifiers, Granberry's previous papers, 0.57 by 5 gene markers. Gale model for prostate, for breast cancer is 0.58. So if we look more closely at this age group 60, as said, a very strong predictor of cancer death. In fact, using a top quartile in the population, you would capture around 90% of the events. And if you then would look at the below 1 nanogram per ml at age 60, you're very unlikely to die from prostate cancer or get metastasis from prostate cancer. Risk estimate, point estimate for death was 0.2. And of course, the question appeared, is this population here in southern Sweden, in Malmö, just neighboring Copenhagen, is this absolutely unique? Is this something that is just sort of has occurred in this population, can never be applied to any other population? We've asked that question, so we went north to the Västerbotten Intervention Project headed from the Umeå University. A population of 40,000 men invited in the early 90s, given then that they were invited years later, there is, at least during the 2000s, some PSA testing in this population. So we see during the 2000 increasing incidence of T1C cancers in this population. The age group 60, 17,000 men with close to 1,000 cancers diagnosed. And amongst those cancers diagnosed, there were around 150, 160 men with metastatic disease which had evolved. And here is then the depiction of PSA measured at age 60, absolute risk of distant metastasis, and years of follow-up, and provided in a graph very similar to the other ones that I provided. And as you see, this looks very, very similar. It does not only look very similar, because if we look at the the point estimates for risk in the Malmö preventative project for metastasis by 0.5%, in the Västerbotten intervention project 0.6%, and for death also similarly, although the central estimate is clearly lower in Malmö than in Västerbotten. Also, if we look at the association, meaning area under the curve, or in this, as a time to event, it should be presented as a concordance index, is 0.86, 0.85 in these two. Very, very similar. And if we now put that in the context of screening, my lab in Malmö, which still exists and performed until very recently all PSA measurements in the Swedish arm of the European randomized screening trial, which has also been published as an independent trial because the original trial protocol was approved as a standalone trial, and only during the first year did this trial join the ERSPC, so therefore there was a mandate to publish after 14 or 15 years. And you know that those data show a very clear evidence of mortality reduction in the Swedish arm of the ERSPC. So using then our data for the men aged 60 who attended screening in Göteborg, we compared these individuals with the unscreened group from the southern city of Malmö. Here's the west coast city of Göteborg, where I actually was born once upon a time, quite a long time ago now. And this is then the result reported in 2014 with Sigrid Karlsson as the first author, looking at the influence of PSA level on the benefits of PSA screening using the Göteborg data on that. And those data show very clear that individuals with a lower PSA, a PSA below, clearly those men with a PSA below median, they absolutely have no benefit of screening, shouldn't undergo any more PSA testing unless they would be anticipated to live well into their 90s or over, as far as we can understand at the moment. For men who have a PSA in the top quartile of PSA in the population, there is also very clear evidence. And the evidence is then that for these individuals, there was a large reduction in cancer death, and that the number needed to screen and the number needed to diagnose became very, very favorable for these men. 23 NNS and 6 for the NND in the follow-up time of 15 years that could be used in this data analysis. So I think we're starting to understand some properties of the PSA test. And this is then shown from the Västerbotten cohort. Here is PSA levels on the x-axis. The different shades of brown is then showing in these type of values the distribution of PSA values in that population, showing then that the median is 1 and that the top quartile is 2. And then in a dotted green line is a 15-year risk of metastasis in this population. Absolute risk here on the y-axis. And in the blue line is the 20-year risk of distant metastasis in this population. That clearly depicts and fits with all other data we have at hand that PSA is a early indicator of risk of distant metastasis and or death from prostate cancer, meaning severe morbidity. And as long as you stay low in your PSA, you remain at very low risk. It also tells us, oh, there should be something more. Where did that go? Ah, it went somewhere. So it tells us actually that if we have a PSA above 2 here with the 20 years of follow-up, we capture 75% of the metastasis cases. However, it also tells us by the 15-year follow-up mark that the vast majority of men with the PSA elevation do not get the event. So truly, this is not a very specific marker. So therefore, using it to exclude risk is sensible. Using it in terms of acting only on the PSA elevation is not sensible, because it's not specific enough for that. And as we know that also most men with a high PSA do not have prostate cancer. So how have we approached this? Well, our approach actually stems from quite a while ago, when I was a PhD student, and by end of my research, which was on the reproductive field, where we studied male reproductive function, and where I then came to discover that PSA is a catalytic proteolytic enzyme, and that the catalytic action of PSA is responsible for the transitioning from of the male ejaculate into a solution, through that it degrades then the gel-forming proteins. And then later on we learned of that PSA is not the only type of this protein produced by the prostate, but also that a very similar protein called the kallikrein-related peptidase, 80% identical to PSA instruction, also is a proteolytic enzyme and possibly also may be involved in this reaction. They are both highly specific in terms of their abundance to the prostate epithelium, and their expression is regulated by the androgen receptor. Now, the aspect that brought biology into this is that it wouldn't make sense for PSA to exist on its own in the blood as a blood biomarker. And the example from that we can take from pancreatic cancer and pancreatitis and other pancreas diseases, where we have a release of the proteolytic enzymes in the pancreas, and where we clearly, for example, in the acute pancreatitis, can see that that can lead to devastating consequences unless the proteolytic activity is being regulated and strongly regulated. So that has then been the theme, to look at regulators of activity of PSA, though PSA is not as aggressive as trypsin or chymotrypsin, but still may be in need of regulation. And from that stem then the discovery of that PSA is being bound, for example, with the alpha-1 anti-chymotrypsin, and then that some parts of PSA in the blood was not bound and exists then in a number of different forms. And then based on that, we built stepwise, first a free PSA assay, which we could show that combined with the total PSA was an independent predictor of risk of prostate cancer compared to just level alone. And then building on identification of the heterogeneity of the free PSA, we built another assay which recognized some processing changes that had an impact on the function of the free PSA, which is called then the intact PSA. And then we also built an assay for the kallikrein-2. Now, some smaller studies suggested that these could be discriminatory in prostate cancer. But the large question that was present at the time when I moved to New York 13 years ago, almost on the day as of today, was then, does any of those assays compared to total PSA alone make sense? Would they have a clinical value? And could we provide a means to try to determine whether that would be so? So in then forming a team together with Andrew Vickers, who joined a year or two into that I had been at Memorial because Michael Kettering was moving over to Cleveland Clinic, and Peter Scardino recruited Andrew Vickers to work with the urology team. So together with him, and he as the primary individual of designing statistical methods and an algorithm that could incorporate these measurements, and then look, our first endpoint was any cancer, any grade cancer. But as we all know, this is not sufficient to do well on that, because we also need to do very well on the cancer of a higher significance, as we certainly were educated much more in depth on here just some minutes ago. So Gleason score 7 to higher, Gleason score 7 or higher, which we just call high-grade cancer for ease of context. And then setting such models up, we started then to look around in different settings how this performs. And the main assets that we had was that we could go to the European randomized screening trial, the Swedish trial with both unscreened and previously screened or recently screened men, the Rotterdam Center with unscreened, recently screened, and previously negative biopsy, France with both screened and unscreened. And overall then, from the early report of Göteborg in 2008, a bunch of papers coming out in 2010 from both Göteborg and Rotterdam, and then later on joining by some recent publication during this year and last year, we have overall then dealt with biopsies from some 14,000, 15,000 men and some more than close to 5,000 cancers. And then just showing the important endpoint, meaning how well can we discriminate high-grade cancer in terms of using these additional markers compared to using a standard model using PSA and age. We see very constant enhancement and improvement in the characteristics you're doing this, and where the overall summary of these characteristics is that we are on at worst a very high 0.7s in the area under the curve, but reaching around mid 0.8s, and that the enhancement degree is somewhere in the range of 8 points on the area under the curve. Some recent studies that have added to that is the Stockholm 2, where this was evaluated, the Malmö community cohort performed together with Anders Bjartel, and the large trial in PROTECT using both plasma and serum, and as you see, very constant results. And to show you some of the clinical implication of these findings, I want to use the largest and also one of the most recent studies that we performed, which was on the basis of the randomized trial in UK, the PROTECT study, led by Freddie Hamdy and David Neal, inviting over 200,000 men, 82,000 men responding to having a PSA, having a blood drawn and PSA measured. invited from the early 2000s. 8,500 men with PSA elevation, just as we expect around 10% of these men. Close to 90% of these men who had a PSA elevation underwent a biopsy, and the vast majority of those, they had a research specimen collected that we could get an aliquot from to be able to do the measurements on either cryopreserved plasma, serum, or on both, and to look at that. And you've seen the area under the curve. So what is the clinical implication of these findings? Well, the clinical implication are being explained by this graph, which may be difficult to grasp immediately. But it is an example of the study design where you had everyone who had a PSA elevation above 3 were recommended a biopsy. And this is then counting on 1,000 men having a PSA above 3 and coming for a biopsy. And then using then the risk estimate given from the Kettering model, in these numbers here, you can take any number and calculate what's your capture in terms of high-grade cancer, where in this example of 1,000 men biopsy, there were 133 high-grade cancers detected. And if you would then take a tentative cut point of, let's say, 6%, you would capture 90% of these ones, meaning 119 cancers. And what's the benefit then? Well, the benefit is then that you could reduce your biopsies by 43% around, 42.8%. And the question, of course, remains, is this good? And what is the Gleason worth? And is this really what we want to get at? And can we be happy with this? Well, then we have actually done something that I think nobody else has done in this field. We went back to the northern Swedish cohort. And in this example that I'm going to describe first, which is shown in one of the graphs on the European Urology paper that was, I think it was in the July issue. It may have been, I may be wrong on that, of last year, where that appeared. As I said, we had 17,000 men aged 60, and in this case we looked at the men all of the men who have a PSA about 3, and here we see their cumulative risk of distant metastases years out when they have a PSA about 3. Now we have also then measured the markers on these men. And if we then use a slightly different risk score than I discussed before, we use the 7.5%, we see that individuals who have at or above 7.5% risk, 62% of the men, of all the men who had a PSA about 3, distribute in that, so you eliminate 40%, and you see their risk, which is high. But more remarkably is then the individuals who have a high PSA, but they have a low risk score. And if we look at them many years out in that setting, they have a very low risk of distant metastasis. And of course then in this setting we could again then repeat to see that the model provided a substantial increment increase in C-index compared to PSA alone in this setting. Another example taken from the supplementary tables, and here put in graph, showing then for the age group who were age 50 when they attended in the northern Swedish cohort, and again the age group at 60 in this cohort. Here shown then for a PSA above 2, which is at age 50, is a top decile. And at age 60, it's a top quartile, as we have discussed before. And here you then show then exactly the same risk estimate, tentative risk action point or cutoff or whatever we call it, that I discussed in the PROTECT study, 6% risk. Less than 1/3 of the men here, age 50, have that risk, and this risk or distant metastasis years out, compared to almost 3/4 of the men who, with this risk, are at very, very low risk of distant metastasis years out. And you see a very similar type of scenario in the age 60 group, with the risk group separation by the Kettering model. So what we have shown in this is that not only for the cancer on the biopsy evidence endpoint in terms of tumor grade, but also in longitudinal settings on men who haven't been actively screened, we can see that this setting discriminates risk in a way that we actually wouldn't have anticipated to start with. So I think what I discussed with you is that a risk stratified approach to prostate cancer risk assessment and biopsy would make sense. Our data from the Västerbotten cohort is the first one to identify biomarker that enhances the ability of PSA to predict long-term risk of developing lethal prostate cancer. And we can also then see by a number of iterations in different cohorts that the Kettering marker-based model reduces the number of false positive PSA tests and has a preference in capturing high-grade cancer. And in men with modestly elevated PSA, the Kettering model can be used as a reflex test to better identify those men who we would then suggest would be in larger need for a biopsy. It's clear that much more data is needed, so therefore ongoing studies where the first one to be presented at the AUA is based on the PLCO, the US screening study, and the biopsy sample on that. We are coming relatively close to be able to put together and report on the largest arm of the European screening trial, the Finnish arm of the RSPC, also on the biopsy sample. And then to make an independent replication of the northern Swedish data, we of course go back to the southern Swedish data and look at that, while we then also are looking into the EPIC cohorts to be able to report from that later on also. So at this time, I just thank you for your attention.
Muchas gracias. Thank you.